called Dr. Nakayima Christine from the Radiology department, and we're going to look at X-rays and investigations that were done with an understanding of what the patient has. So just a little bit of orientation about a normal chest X-ray. It's not, I believe we have done the gross anatomy. So this is the radiological anatomy, and those are the features that we see. We go from this is the trachea, this is what we call the carina, which bifurcates to form the right and the left bronchi, principal bronchi, and this is the heart shadow. Okay, I think we can appreciate it. And this is the vertebra behind with the spinous processes and the vertebral bodies. This is our rib cage, and these are the ribs. Okay, so this is the normal radiological anatomy, how the chest should look like. And because our patient also had CT, so these are few cuts which I could be able to get for the CT, because we give it at different levels. So depending at what level the cut has been made, those are the structures that we'll be able to appreciate. So we have a little bit of orientation of at what level, what is the cut. So for most of us who are not radiologists, you can always have the film. It has the markings of where the cut is being made. And from this we can, this is the right and this is the left lung. At this level already we have found that our trachea has already bifurcated. It's giving us the right and the left principal bronchi. This is the ascending aorta. So it depending on the series, sometimes they are contrasted and they're non-contrasted. So some of these structures look brighter in some cases, and others they look dull. So you appreciate the fact that they are contrasted when we have added a reagent to enable the structures come out better. Okay. And from the patient, this is the radiograph that we are able to appreciate it. My colleague tried to display it, but it was a little bit not clear. And I think we can all appreciate from our first anatomy that actually there is a problem with this chest X-ray. That what was dark initially, what we call radiolucent, is actually bright. It is opacification of the lung, of the left lung. And then the right, you can see some bit of radiolucency, which is the right lung. This is our left lung. We cannot appreciate the cardiac shadow, but if we look closely from up, we'll be able to appreciate that this is supposed to be, this is our the trachea, the patient's trachea, but it has moved. It is no longer in the center where it was supposed to be. And from the opacity on the left side, there are no air bronchograms. We are supposed to see like structures, thin structures going through the lung markings, which are the air bronchograms, which are devoid on this X-ray. And what we call the positive silhouette sign is the heart shadow, the contour of the heart has been obscured. You cannot be able to see it. We cannot be able to see the hilum, which is supposed to be here. So basically, the other features of this X-ray, we have, we've talked about the mediastinal shift. That means that the trachea, the heart, the hilum has all been shifted to the right. And there is compression of this right lung, so with loss of lung volume. And the costophrenic and cardiophrenic angles are sharp for the right lung, which we cannot be able to make out on the left side. Okay, so if we only had this radiograph, we would have our differentials to say that there is a massive pleural effusion. It could be an empyema, it could be due to bronchogenic carcinoma, a lymphoma, or a pneumothorax. But because this patient did not have any prior trauma, we could not be able to say maybe it's blood. Depending on if we tap, then we can be able to differentiate whether it is blood, it is pus, it is clear fluid. So the differentials still, from my colleague up, they will still stand that we could have so many differentials for having this unilateral massive pleural effusion. We cannot take out the lung collapse or the lung tissue because we cannot be able to appreciate it on this radiograph. And the patient further went and they did a contrasted CT scan. These are some of the images. The cuts that we got, they're below T5 because we cannot be able to appreciate the trachea. But this is a esophagus, and this is the heart shadow. It has been deviated, okay, markedly. At least we can all appreciate that. And this is a homogeneous hypodense region. And we would appreciate that when we see such, we think this is fluid from the Hamsfield units. We usually indicate them. And from this we go 25, which lies between, it is not water, it is not, because blood we usually give it 40, 50, water is 0, so it is in between there. So I could not be able to appreciate whether it is, it's in between the two. It could be blood, it could be water. So, and these are different windows. These are the different windows that we have, and this is a lung window where we can be able to appreciate well the lung markings. And when you look at this, the fourth CT radiograph, it looks like this other side has nothing. It looks like it's empty. So if I had only this without other images or the X-ray, someone would think this patient they had removed the lung or anything. So those were the CT. This is a coronal image. The other one to your axial. Still, we can appreciate the right lung, although it is the volume is reduced, and the hypodense lesion, which is occupying the whole of the left lung. So from this lesion, it cannot be a mass. We wouldn't say that it's a mass because of a hamstring units, but we still appreciated the mediastinal shift. So this patient the attending physicians went ahead because of the first radiograph. It was a pleural effusion, and a chest tube was put, and this is a repeat. I don't know how the time, but it was a repeat, and you can appreciate that still our tube is in situ. This is the chest tube which was inserted. It goes up to around the upper zone towards, this is the clavicle. So at the anterior border of the clavicle, that is the end of the chest tube. And there is the trachea. We have appreciated that right now the trachea is central compared to the first images where it was more deviated to the right. It is more central, even the mediastinum, but still we cannot still appreciate the silhouette sign. The cardiac border is obliterated by the opacity, and in this radiograph we can appreciate different densities. We have this radiolucent density, which is devoid of lung markings. So because at first when you look at it, it looks like this is lung tissue, but because it does not have the bronchovascular markings, then we wouldn't take it to be a lung tissue. But there is another soft tissue density which has some bit of lung markings, and from the impression I would think that we are having some bit of collapsed lung. It doesn't look like this normal lung, but this lung is actually collapsed. And this is our tube. So from that, we see that yes, the patient was getting a little bit better, because maybe the patient right now is feeling a bit of relief. The trachea is back to normal. The breathing may be better. I don't know, the managing physicians. So after some time, the patient was taken back, and we had a repeat. I think it's a month difference, but still, what was appreciated in the repeat PHS radiograph in the first image, most of the features are still evident after some good time, because the other one was taken, I think, in July, and this was August. And we can still appreciate, yes, the trachea is still it's central, but there's still this homogeneous opacity with a positive silhouette sign. This soft tissue density with some air bronchograms, we'll appreciate it that this is most probably the remaining of the lung, or the collapsed lung. And the radiolucent area, which is devoid of the lung markings, is more probably, this is a pneumothorax, this is air, just free air in the pleura. And the air fluid level at this, so we are still having some bit of fluid in this patient. So after that, we will have the differentials from the last radiograph. I would have a moderate hydropneumothorax with a left lung collapse. There's a differential of Empyema. We could have a neoplastic process going on, and then we could recommend a repeat chest CT scan to evaluate the lung, the collapsed lung, and the density, what it is made of. Thank you.